Morning, Aaron.
Hello, good morning. Hello, good morning, Dr. Mukherji. How are you?
I'm doing good. Yourself?
Very well, thank you. Very well.
Excellent.
Great.
Excellent.
Thanks for coming slightly earlier. Um, um, and the Zoom room has capacity for 100, unless radiologists are coming. Neurosurgeons usually don't. So I got about 100 and about 200 names, but not everyone usually comes. So usually 100 is more than enough. But in case anyone comes, in case
Okay.
there are 2 minutes, so that's why I just wanted you to just log in so that you're already in the room. And Dr. Jason Chiang is joining.
Yeah. Yeah, no problem at all. I didn't spread this out with
Oh
the
no, no,
radiologist. I sort of kept it amongst ourselves this time.
that's brilliant. Thanks, because what you call it's very rarely it goes over 100, and then you have to go to the next tier of Zoom, which
Right.
the the tier jumps quite a big by a big
Right.
margin in terms of the Zoom.
Right.
So I don't mind if people actually come, but I'm also live streaming it on the YouTube, so people can join there. Hello, Jason. How are you?
Hey, how are you?
Very well, thanks. Very well. You have met Dr. Mukherji before, so
Yeah,
but,
Hey, Jason, how are you?
good. How are you?
Good, good. Excellent.
I'm just going to
I
send
always
an email,
I
and
always
I'll
enjoy Jason's comments.
Sorry, Dr. Mukherji.
I said I always enjoy Jason's comments.
Yes, absolutely.
Oh, thank you,
Yeah.
thank you. Yeah, I'm trying to be helpful. Um,
Ah, mission accomplished.
I hope so. I hope so.
Hey, Naren, when Dr. Boop starts to talk, I'm gonna remove my picture, right? I'm just gonna listen in the background.
Sure, that's okay. You can be on the video as well, but whichever you prefer.
Okay.
Just
Between you and me, I'm gonna exercise. I'm
Mhm.
gonna listen on the treadmill. I always work out in the morning. That's my
Oh, very good. And how is the neuroradiology webinar attendance like, Dr. Mukherjee?
Good
for
morning, you
which
guys.
one?
The radiology ones always have 500 and 1,000 people. Is it
Yeah.
still running at that number?
Yeah, we did for Modality, the one company, I should say one, it's the educational group that I work for. I
Mhm,
did a webinar with them on Thursday,
mhm.
and we had 1,300 registrants.
Wow. And how
Now,
many?
not all of them attend, but it's also available asynchronous, so they eventually go back and many go back and look at it on the archives.
And how many turned up of the 1,300 that registered?
I think we had between 350 and four.
Okay.
So
That's
in
pretty.
general, it's about a 25 to 30% hit rate
Mhm,
for all the webinars I give. That's about
mhm.
it.
That's great. I think I also find I do register for many webinars, but on the day, on that time, something that comes up, in the
Yeah.
days of when it was, in the days when it was COVID, you did not have, there was nothing else competing. But now,
Well,
um,
they're all available in the archives. So
yeah.
if someone wants to look at them, just go to Modality and you'll get it. And then also a lot of them, now have 22 lectures on my YouTube channel.
Oh,
So if anyone if is interested there, they can just go there and watch it for free. Some of the lectures for free.
oh, good.
Could
Yeah.
we put them on our ISBN library,
Oh, yeah.
Suresh?
I would love that.
If you
Oh,
could, at the end, if I can get your email, I can send you some information on how we can upload those lectures to the library. It's a wonderful repository that's free for everybody in the world, whether they're
Okay.
physicians, families, whatever, but that would be great.
Yeah, let me just send you my email through chat. I'm not an IT person myself, but I'm happy to work with you or whoever to upload it
Perfect.
Send that.
Glad
Yeah, I
to.
just read a paper of yours, Dr. Boop. I was there was a colleague of mine, Tina Young Poissant up at Boston Children's. She's the chair of radiology, and I was in preparation for this. I was looking over a couple of her talks, and I know you have recently published a paper on ependymomas, if I recall. I think it was or medulloblastomas or something in 2022. Was it was a multidisciplinary or consortium report.
Could
Do you
be.
recall that paper? Okay.
Yeah, I know they St. Jude just sent out a pineoblastoma article to Nature that had my name on it too. Morning, Jason. Good to see you. So, Naren,
Hey, good to see you.
should I try to share my screen and make sure that'll
Yes,
work?
thanks. Thank you. Dr. Mukherji, the ISBN library is very impressive,
Yeah.
and I mean, the video library, that's the one that I have looked at. It's fantastic. And I remember, there's a lovely, excellent video from Mr. Dominic Thompson from London on myelomeningocele repair. And it's so beautiful and so clear, and someone who has done it for years and who knows inside out. And you can watch it and you can actually do it yourself next day. It's that good, isn't it, Dr. Boop? I mean, it is.
Yeah.
I mean,
Dom has the most beautiful lecture I've ever seen on spinal embryology, how it relates to neurosurgery and congenital abnormalities. I saw him give the talk at the ESPN Fellows course in Oslo, and I was just blown away by how great it was. So anyway, let's see if we can make this work.
hopefully. Yep, that's brilliant. And
There you go.
oh,
Can you see it?
yes, that's
Yeah.
beautiful, very beautiful, Dr. Boop.
This is our new place in the Smoky Mountains in East Tennessee.
Wow.
It's still under construction, but we're making good progress.
Is that a snow behind? I mean, the house is beautiful, setting is fantastic. Is that snow or cloud?
It's snow on the mountain top.
Oh,
I took this picture a couple of months ago,
wow.
but yeah, it's a gorgeous place. Nice, peaceful place.
Amazing.
Let's see if this
Videos.
that's showing okay.
Yeah.
Good. I think we'll be ready then.
Oh, great. And I'm live streaming it on YouTube, Dr. Boop. You're okay with that?
Absolutely.
Oh, fabulous. That's great.
Yeah, I think you guys will probably recognize a number of these slides. But the case presentations make some good points. So
It's a really great presentation. It was Dr. Boop sent me a backup one. It was fantastic. So, hello, Professor Goel.
Atul, good to see you.
Yeah, Fred.
How are you?
Naren, I'm looking forward to this presentation, and I'm sure it will be fantastic. So,
Well, you're very
thank you very much
It's good to see you.
Thank you for organizing all this, Naren. My best wishes to you.
Oh, thank you very much. Thank you very much. It's I think it's important that these webinars keep going, and I think it's important that as many participants do come, because as the conferences start to come back into swing, and to have the speakers of caliber to come to these webinars is still important with these with the registration fees of these conferences, and also these webinars do allow more time to discuss. What's your thoughts, Prof. Goel? You have been in webinars in different continents, as with Dr. Mukherji and as with Dr. Boop. Where do you see how can we keep this going?
No, there is no question, Naren. These are very important. It is a most important platform to take the message of neurosurgery deep into the world of neurosurgery. It is freely available to everyone. There is no need to travel, no need to, it is so damn cheap. and to get information from the top of the topmost of the world. I think there is no platform as wonderful as this one. And now you're having Frederick. Frederick is the most respected pediatric neurosurgeon. Now his message is going deep into the corners. Now, who wants to listen, who doesn't want to listen, that is not the thing that we have to evaluate. How the message is going, how it will be recorded on YouTube, how it can be, reinvented. And, this is the most useful, fantastic teaching tool that COVID has taught us. And I think we should just take it forward and take it ahead the way we can. Naren.
Yeah, thanks, Dr. Thanks, Dr. Professor Goel. I absolutely think so. I think, I do go to conferences. I do love conferences, but the talks go so quickly unless you have got a, as I said, my brain chips were put in 1970s. And, and unless you have some sort of new 2025 brain chips, it's difficult to quickly absorb complex stuff as the speaker gives it in a 5 or 10 or 15 minutes talks, but these ones really go. And the other thing is that, to be honest, these lectures are mainly attended by uh, participants from not UK or not US, and that is one of those, but it's certainly most used by people from other countries. Professor Boop, your thoughts on how to keep these webinars going? I know that some societies, are struggling, but they do get sponsorship, so they're okay. But
I think you are probably one of the leaders in the world of neurosurgery at keeping this going, Naren, and I agree with Atul. It's high quality sound, high quality visualization, and now with Google Translate, we can change the language for people that don't understand the language that it's on. The ISPN gives courses around the world 5 or 6 times a year. They'll be in Shanghai this next week putting on a course, and we're now recording those lectures and putting them on the library too. But for the price, I really think that this evolution that came out of the COVID pandemic is something that has leveled the knowledge and the technical expertise in our field around the world, because everybody can see what's happening on all the continents through these lectures.
Absolutely, I think,
and I'm really glad Jason's here, because he can explain to us things that I don't understand when it comes to the molecular genetics of the tumors and the different platforms we have now, like the nanostring technology and things like that purport to give us pathological results in 90 minutes or whatever.
Absolutely. Thanks. And Dr. Mukherji, you have taught around the world, and what's the impact? And you do travel, and what's the impact has it been?
No, I agree with everything it's said. I think part of it is, I'll give you my philosophy about what sort of drives me. My brain chips were placed in the early 60s. So my chips are even older than yours. But I think what drives me these days is the democratization of education around the world. I think if people that are high resource countries can obtain their information everywhere. But as I think part of our goal as educators and clinicians is to try to reach parts of the world that had never been reached before. And now with these platforms, you have the opportunity to do that. I know I probably give about 3 or 4 lectures every week using these platforms. And even with the YouTube channel that we have right now, I can't believe we have over 3,200 subscribers.
Wow.
And like you said, a lot of these people from all over the world and how they find it. So I think number one is the democratization of education, and then trying to do the right thing. And then secondly is, I realize I'm not smart enough to make an iPhone or something like that, but I think in my own little way, I just feel it satisfies my soul that I'm making some type of contribution. And so personally, I don't ask for anything from it, but the occasional kind comments I get, that's enough to keep me going at this phase of my life.
Thanks. Thank you, Dr. Mukherji. I think sometimes we don't get the survey from the people who actually mostly find it useful. maybe that might be something to be done. How much it has changed, because if you go back to Sri Lanka, where I came from a long time ago, you'll never you'll be lucky to go to one conference, international conference in your life, and now you can be at home and watch all the best people give a insightful, and I'm always keen to get the top echelon of those, because then you give a balanced view rather than someone who's on the up who wants to impress. So I'll ask Nicholas. Welcome, Nicholas. Do you have any comments?
Good evening, everybody. It is a great pleasure and a great honor to be with you, dear Naren, and all friends. And it's also a great honor to be with the Professor Boop that I met some years before in various conferences. And of course, my dearest friend and professor and mentor, Atul Goel. Naren, 10 days before, I was with many friends, also your friends in the ESPN Congress in London. It was a great Congress as always. It was also Dr. Jallo, and we speak a lot also about you. But I don't speak about this Congress particularly, but it is too much the cost of traveling that sometimes for the young neurosurgeons and young neurosurgeons across the world, it is prohibited the prices and the traveling. And UK, for example, it is very huge the cost. This marvelous webinar that you organize, as Professor Boop said before, you are the master. You are one of the master, because there is quality and quantity of these webinars. Perhaps it is a unique way for the young neurosurgeons to meet these great personalities and to discuss about the various topics. Naren, thank you very much for your friendship. I'm proud of being your friend, and I will be glad to hear this very nice webinar about Ependymomas, and greetings to all the great friends and participants. Great honor to be here. Thank you very much.
Thank you so much, Nicholas. You have been always very supportive of these meetings. I think we are on time. It's 1 o'clock, so I will start the webinar. So welcome everyone to this pediatric neurosurgery webinar. And I know for some of you it's very early in the morning, and for some of you it's late at night. So thank you for joining us. We have got excellent world-class speakers today. We have got Dr. Boop, who's going to talk to us about ependymomas. Dr. Boop does not need an introduction to neurosurgeons. However, many of the participants today are from neuro-oncology, neuro-radiation oncology. Dr. Boop is emeritus professor at the Department of Neurosurgery at University of Tennessee. He was the past president of the American Association of Neurological Surgeons. He was past president of the International Society of Paediatric Neurosurgery and many other organizations. He is considered one of the giants of pediatric neurosurgery, and certainly a pioneer in terms of pediatric brain tumors. And also he has contributed immensely to pediatric neurosurgery education for us in the listserv, as well as ISPN and in other forums internationally. So it's an honor to have Professor Boop to give us his very insightful lecture on ependymoma. We have, in terms of our faculty, we have got Dr. Jason Chiang, who will later on give us a talk to us on molecular biology. I'll introduce him then, and he's a neuropathologist. And Dr. Suresh Mukherji, he is one of the giants of neuroradiology, It's a real immense honor to have him with us. Once again, he has got several professorships in America and several professorships outside America. So if you want to know about him, you are welcome to Google. If I start telling about him, it will take another 15 minutes. So, but he's a great educator and great to have him with us. And we have got Professor Goel, a giant of neurosurgery. So we have got a great team to discuss. But I also want questions from you. There's nothing called a wrong question, and please feel free to ask your questions. As they say, that when you ask a question, you get rid of you become enlightened. Otherwise, there's a chance that you might have the same question forever. So feel free to ask questions. Put your hands up or write your questions onto the box, and I'll bring either you live to ask the question or from the chat box. So without further ado, Professor Dr. Frederick Boop, we are looking forward to your lecture. Thank you, sir.
Well, thank you, Naren, for the opportunity to share my personal experiences and biases over the last 30 years in this interesting disease. And I'm glad that my colleagues are here to fill in some areas where I have limited knowledge. Let me start, and I'll plan to talk for about 40 minutes before we pass the baton, but I'll let you be in charge of the chats if you don't mind, Naren.
Sure.
So this is an unusual presentation of a child that came to us about 10 years ago, and he came on a holiday weekend on a Sunday morning. His family said he'd been in this position for 3 days, and he was wide awake. He could talk. He complained of pain in the back, upper back, and they'd actually taken him to our emergency room 3 weeks prior because he had pain between his shoulders, and the ER doctors had done plain x-rays and said it looked fine, but they did note that he had some mild torticollis at the time. So this is his CT scan, and you can see acute hydrocephalus. You can see a posterior fossa that is completely filled with tumor, craniocervical junction with no subarachnoid space. And so he's holding his head back to try to decompress the craniocervical junction. And so the question that we were faced with is it safe to sedate a child like this and straighten him out to get an MRI? And how are we going to put his chin to his chest and position him for posterior fossa surgery to take out this tumor when he's in such shape? And I'll let you think about those issues while I give you some background on this disease. So when we look at the pie chart of pediatric brain tumors, this side are supratentorial tumors and this side are posterior fossa tumors, and you can see that ependymomas make up between 5 and 10% of pediatric tumors. So if I tell you that the average children's hospital sees 30 to 40 brain tumors per year, you can expect that most children's hospitals outside of being a referral center will see 2 or 3 of these tumors per year. The important thing about ependymomas is that most of them are intracranial in children, 2/3 of them are in the posterior fossa, but 95% of these tumors are localized at presentation. And that means we as neurosurgeons have an opportunity to cure these children at that time because it's unusual for them to present with disseminated disease, at least in my part of the world. Historically, though, the 5-year progression-free survival has not been great, and the time to recurrence is short, typically within the first 2 years after the initial diagnosis. And keep that in mind as we go through this talk, that for a young child, a 3-year-old, for example, like this child, who hopefully has 80 years of life ahead of him, this disease oftentimes will come back within the first couple of years. So if we get out to 5-year survival, that is meaningful in these children. The other is that this tumor is radiation sensitive, and so we have that adjunct to help us in some cases, but we'll explore that further. In 2009, Tom Merchant published our series of ependymomas in children, and this was 153 children at the time. And you can see that in terms of overall survival, we had about 80% control of these children with aggressive surgical approach. Many times, these children require more than one operation to take the complete tumor out. And for this localized cancer that has yet to spread, that's the most important contribution in every series to their long-term survival. In terms of chemotherapy, it continues to be controversial. If you're a neuro-oncologist, then I think you'll probably remember cases where you've seen a response to chemotherapy, particularly in young children with anaplastic tumors. But it's important to recognize that overall, chemotherapy usually does not prolong overall survival. And so we can use it in certain instances. For example, in a young child with a large tumor, if we can get it to shrink some, it may facilitate a return to surgery for a gross total resection. In a young baby with a hypervascular tumor where we're worried about blood loss, a single round of chemotherapy before surgery can oftentimes knock out the blood supply to the tumor and allow us as neurosurgeons to operate on the children without having to worry about exsanguination during the operation. So there are uses for chemotherapy, but at the same time, remember that when we give children chemotherapy, 5% of those kids 10 years down the road are going to develop blood-borne malignancies related to the chemotherapy. So unless we have a significant improvement, there is a trade-off with giving chemotherapy just because we don't have anything else to give. In our first RT1 protocol, we had a prospective study of 50 children. These were all less than 3 years of age. And what we found, as in every other paper written on ependymoma, is that the extent of surgical resection is the greatest predictor of long-term survival. In those days, the WHO definition of ependymomas differentiated grade 2 from grade 3, with grade 3 tumors having anaplastic features. And keep in mind that most of those grade 3 tumors are going to occur in younger kids. So there's a relationship to that finding. And then in that study, we found that if we delayed radiation therapy to give chemotherapy to these young children, they actually had a poorer long-term survival than if we went ahead and gave them radiation up front. And so now we try to get them to radiation as soon as they're through their surgery. The breakdown historically has been, as I said, grade 2 being differentiated ependymomas, grade 3 having anaplastic features. There's always been some discussion about children who had focal areas of anaplasia within their tumors. And this terminology has now gone away in the 2021 reclassification of brain tumors. And I'll point out that myxopapillary ependymomas have been changed from a grade 1 to a grade 2 tumor. In particular, in children, in times past, if they had an incomplete resection as a grade 1, we might observe a child with cancer in their spine. And we now know that when we do that, we place them at risk for dissemination of their disease through the subarachnoid space, and that's not a good thing. So myxopapillary ependymomas are now grade 2. And in the 2021 nomenclature, the addition of the MYC-N amplified intramedullary tumors, which portend a poor prognosis and typically occur in adolescents and young adults. So here's a case that came to me, a 28-year-old who for 2 years had experienced pain in his hips bilaterally when he coughed or sneezed, and it gradually got to the point where he would his legs would go out from under him and he would fall to the ground. He'd been seen by the orthopedic surgeons who'd done arthroscopic surgery twice on his hips, and to no avail. But you can see on his scan the typical appearance of a myxopapillary ependymoma, encapsulated arising from the filum terminale. and no evidence of metastatic disease, which is typical for most of the children that come to us with this. So you can see we've used a saw to perform a laminectomy so that we can put the lamina back at the end of the case. Here we open the dura. You can see the arachnoid intact. Remember, these tumors are in the subarachnoid space, and that means that when they do disseminate, they can spread through the CSF spaces throughout the central nervous system. And so we commonly will see drop mets to the cauda equina, but we may see metastatic disease to the brain as well. So our preference in these cases is to clip the arachnoid to the dura while we take out the tumor. And that way, when we close the dura, we sew up the arachnoid and reconstitute the subarachnoid space. Here's the filum terminale from which they arrive, and it's important to cut it as far down as you can because there are reports of recurrence of this disease from tumor located within the filum. So trying to get as far away from the tumor as you can, and then having the pathologist look at the filum, keeping the capsule intact as we dissect the tumor away from the nerve roots. And typically the blood supply to myxopapillary ependymomas will come from one or two radicular arteries coming in through the neural frame. And so if we can look out laterally and find where those arteries come in, we can then coagulate them and devascularize, devitalize these tumors. You can see the artery here coming in from the neural frame, and on the left there, there was a nerve root stuck to it. We stimulated it. It was a sensory root, so we were comfortable taking it if we had to. And then where the tumor attaches to the spinal cord, we want to be very careful there. And we've got monitoring electrodes in the anal sphincters and lower extremity muscle groups, stimulating to see if we get a response, and not seeing any response, coagulating and cutting through the end of the pia there. And we will typically put a suture through this so the pathologist can look at that stump and make sure that we didn't leave tumor behind, but had a clean margin. Once we've got that cut and the nerve roots dissected away, we can then remove the tumor, keeping the capsule intact. And if we can do this, this is the best chance for cure, and these patients are not likely to turn back up with metastatic disease. And once the tumor's out, we remove all of this packing material, any foreign body, so that we don't have to worry about a foreign body reaction months down the road, confusing us for recurrent tumor. As you see, we remove these clips as we sew the arachnoid up with the dura, reconstituting the subarachnoid space. So this is a paper by Mark Bilski at Sloan Kettering on adults that he's managed. In his series, about a third of them had metastatic disease at presentation. And since these tumors metastasize in the subarachnoid space, the proper management of these with radiation is craniospinal radiation, which is highly morbid. And oftentimes we will treat them with focal radiation if the mets appear to be focal, but that's something to keep in mind. This is a paper that David Ellison published a number of years ago in the Journal of Negative Results. And what he looked at is the agreement or level of agreement amongst the 5 best neuropathologists in America undergoing central review of our multi-center clinical trials for pediatric brain tumors. And what he demonstrated is even amongst the best neuropathologists, most experienced guys in North America, there was a 10 to 15% discordance in what they described they were seeing under the microscope. And I think that demonstrates nicely why we've had a migration from the subjectivity of what a pathologist sees under the microscope to the more objective molecular profiling that we're now seeing taking over neuropathology nowadays. And you see a great example of that in the new nomenclature of pediatric brain tumors in the 2021 classification. And Jason will address that later on. But if you look here, historically, these tumors under the microscope all look like ependymomas, whether they're posterior fossa, supratentorial, or intraspinal. And yet we all know that their biology is different based upon these locations. These tumors don't act the same. So really, to look through the microscope and say, well, this is a grade 2 or a grade 3 ependymoma doesn't give us the biology of these tumors as well as molecular profiling. So when Michael Taylor was our fellow in 2004, he worked in Richard Gilbertson's lab, and they performed this study where they demonstrated quite nicely the clustering of the supratentorial tumors, the spinal tumors, and the posterior fossa tumors, and were able to show quite clearly that molecularly these were different tumors, even though they looked the same. And they were able to confirm these findings with tissue microarray. You can see quite nicely the difference in these groups based upon the anatomical location of the tumors. They subsequently went on to demonstrate that the most likely embryologic precursor cell for these ependymomas is a radioglial-like cell developmentally. And in speaking with Michael earlier this year, he's got a paper coming out of his lab that he thinks will give us a unified theory as to the embryological development of ependymomas throughout the central nervous system, not yet to come. But we do know from what we had there that if we take these driver mutations from these posterior fossa ependymomas and we implant these cancer stem cells in mice, we can grow tumors that are histologically and molecularly identical to that in the human condition with these orthotopic genes in the mouse. This paper is a neurosurgical classic. It was Stefan Pfister's and Michael Taylor's paper where they first described the two distinct subgroups of posterior fossa ependymomas, posterior fossa A and posterior fossa B, and they demonstrated quite nicely in a good series of patients that even though these look the same under the microscope, they're actually very different. The demographics of this tumor, the PFAs, typically are in younger children. They tend to be a lateral location instead of midline. They're more likely to invade the cerebellum, metastasize, recur, and cause death than are the PFB tumors. And you can see quite nicely the difference in outcome here. When they looked at the molecular changes in these tumors, the PFB tumors had classical chromosomal instability, what that we would expect with cancers, whereas the PFA had relatively little of that. And we now know the reason for that. But suffice to say that when we look at extent of resection in the kids that had a gross or near total resection and radiation, their outcome was quite good in both groups, again demonstrating the importance of extent of resection. Now we have also found that in the posterior fossa A group, the gain in chromosome 1q can be demonstrated through fluorescence in situ hybridization, which can be performed on paraffin-embedded tissue. So you don't have to have fresh frozen tissue from the lab to do this testing, but the significance of the chromosome 1q gain is shown here when we look at the difference in outcome of children with 1q gain in their posterior fossa ependymomas versus those who don't. And this is a slide from David Ellison showing the importance and the difference in outcome. So we now have nomenclature demonstrating 9 different categories of ependymomas in childhood. And when we look at the supratentorial tumors, what was initially called the C11-ORF-RELA fusions, and recognize that nomenclature has now been changed to the zinc finger or ZFTN fusions because they confused other things than just RELA. But Stefan Pfister had published a paper suggesting that there was a much poorer outcome in the RELA fused supratentorial kids. We've not been able to confirm that in our own studies from St. Jude. They seem to do about as well as the apt tumors. So this is a child who came to us with headaches. 3 years old again, and you can see the tumor here. And when we look at the imaging, we can see that it's a cystic and solid tumor, and note that the whole cyst wall enhances, which tells us that that wall is a neoplastic carpet. And even though we've got a tumor nodule here, if we leave this behind, once that cyst collapses, that tumor will coalesce and continue to grow. So it's important to use a surgical approach to these tumors that will allow us to take out that whole neoplastic carpet. The approach we've used here is an interhemispheric approach. You can see the interhemispheric fissure here in the dura, and we're freeing up the interhemispheric fissure. And once we get down to the tumor, you can see quite plainly that the tumor doesn't look anything like the normal pia. So we have a good visual and textural difference between the normal brain and the tumor. And if we can take that neoplastic lining and try to keep it intact and dissect it away from the normal brain, then we have a good chance of not spreading the tumor and getting that whole neoplastic carpet out. And sometimes that neoplastic carpet can be thin and hard to dissect. And there are cases where if it doesn't come away from the brain, particularly around the brainstem or in the posterior fossa, we may end up coagulating it or leaving some behind. But here you can see that the tumor itself is quite different from the subjacent white matter. And being in the frontal lobe, we have the luxury of being able to take some extra brain if we need to, without any clinical ramifications for the tumor. But you can see here the difference between the white matter and that neoplastic carpet as we dissect it away from the child's brain. And then getting it all out. And if there's any question about residual, taking a bit of the white matter as we go. So here's the tumor cavity with no fixed retractors used on the brain because those don't do well in children's brains, but a negative scan at the end. And this child had focal radiation to the tumor cavity and has done well since that time. So this is a paper that Santosh Upadhyaya published along with Ibrahim Kadumi and others at St. Jude. And these are children from our SJYC07 trial. These are infants that had brain tumors. And in this case, they had 54 children less than 3 who had ependymomas. And the question was, if we gave chemotherapy in addition to surgical resection and focal radiation, could we improve survival in these children? And what he was able to demonstrate was that there was no difference in the progression-free survival by the molecular subtyping. We had 42% survival in the subtotally resected tumors and almost 80% in the gross total near total. And there was no difference by histological grade, and there was no significant difference in the kids who received chemotherapy. Once again, in my mind, suggesting that as historical papers have shown, that routine chemotherapy for these children does not extend survival. So here are 9 subtypes, and I'll make the point that for the spinal subependymomas, posterior fossa subependymomas, supratentorial subependymomas, those are adult tumors. We don't see them at children's cancer centers, whereas the others are more likely to happen in infants. A paper again from Stefan Pfister and Michael Taylor working together with a large number of children with ependymomas and demonstrating the epigenome and the epigenomic trimethylation changes that we see typically in these posterior fossa ependymomas. So back to our patient. Here he is in the operating room. He came at a time where we had our intraoperative 3 Tesla intraoperative MRI. So he's on our intraoperative MRI table, still awake, but as you can tell, he doesn't look like he's feeling too well. We gave him mannitol and Lasix, put in a Foley, had anesthesia, put him to sleep, and then put in a ventriculostomy and gently let off CSF down to about an ICP of 20, trying to be judicious so he didn't cause any upward herniation or hemorrhage into the tumor. And his vital signs remained stable through that. So we then turned him prone, watching his vital signs. Here he is in position. We did an intraoperative MRI demonstrating this large posterior fossa ependymoma extending out both foramina of Luschka and down to the level of C3-4. And you can see here the tumor growing out the foramen of Luschka on both sides. Craniocervical junction, the cord is flattened. It's no wonder that he was extending his neck. And once we had it exposed, then we started down replacement laminoplasty down to C4, and then starting down below, trying to keep the capsule intact as we dissect the tumor away from the spinal cord, then coming up above and dissecting the cerebellum away from the tumor. And typically, most of these tumors are not hypervascular, and you can see why some have called these tumors plastic ependymomas, because it's like someone poured plastic into the posterior fossa and they just filled in all the cracks. We look early on around the tumor to demonstrate that it's not invading the floor of the fourth ventricle. If it is, we're much more cautious about manipulating the tumor because we know we're manipulating the brainstem when we do. Then debulking using the ultrasonic aspirator. Like all midline posterior fossa tumors, these tumors are fed from the vermian branch of pica. The brainstem perforators come off during the tonsillar loop, but from the obex and above, the vermian branch can be sacrificed in young children if necessary. In these cases, we look for the perforators coming off to the tumor and try to coagulate and cut them and devitalize the tumor as much as we can while we debulk it. We put lots of gel foam around to try to prevent blood and tumor cells from spreading up into the third ventricle or down into the spinal canal. And my personal feeling is that many of these children who recur in the subarachnoid space do so because of iatrogenic spread of the tumor. Once we've debulked the fourth ventricular component, then we'll turn out laterally and work in the CP angle to try to remove the tumor away from the cranial nerves. And in young children, it's critical that we try to remove the tumor from the nerves and not move the nerves from the tumor, because it doesn't take much manipulation of the 9-10 complex for these children to wake up with dysphagia and to aspirate. Once we've gotten the tumor out laterally on both sides, then we'll remove all the packing material, looking cautiously all around in all the nooks and crannies, trying to get out every last little bit of the tumor that may be stuck here or there. And once we've got it all out, we remove all of the gel foam, all of any foreign body material we don't want to leave there, because we know 6 months down the road, a foreign body reaction will make that stuff start to enhance, and it will confuse us about whether the child has recurrent disease or not. So you can see here, both of the vermian branches of pica are preserved. The obex is free. The ependymoma is intact. And this is our intraoperative post-op scan in this child showing a complete resection. And here he is in the clinic 2 weeks post-op, coming back for a follow-up checkup. He stole my reflex hammer and told me he wanted to become a neurosurgeon when he grows up so he can hit people with a hammer like I do. So he went on to focal radiation and has done quite well. But you can see the conundrum here. This is a typical PFA CP angle ependymoma with basilar artery encased, cranial nerves encased, tumor growing out the porus acousticus, and ependymomas love to grow out skull base foramina if they get a chance. Most of the time, if the capsule's intact, we can tease that tumor out and get rid of it, but that's a common site for residual. And as these grow from tumor rests at the lateral aspect of the foramen of Luschka, they'll enlarge up and down and they'll rotate the brainstem so that when we get there as neurosurgeons, the brainstem is turned up on its side, and the anatomy can be quite distorted. So to approach these, we've tended to use a hockey stick incision that can allow us to move the bed and work between the cerebellar hemispheres to get the fourth ventricular component out, then turn the bed up laterally and come in from a retrosigmoid or subcerebellar approach to the CP angle to get the tumor out away from the cranial nerves there. And using this approach, you can actually get all the way across the midline in these cases as you debulk the tumor. And it's interesting, if I give a neurosurgeon a picture of a acoustic neuroma, everyone will say, do a retrosigmoid incision. But if you give a pediatric neurosurgeon a CP angle ependymoma, every one of them will make a straight midline incision. And there's no way you can get the tumor out from in front of the brainstem from a midline posterior fossa incision. So when we get these recurrent kids, we'll hockey stick that over and make a large posterior fossa craniotomy. We prefer what we've called the forehand operative technique, with two surgeons operating across from one another. And even when you're short like I am, operating with a tall person, this is a very comfortable position for us to operate in. This is another paper from Michael Taylor and David Ellison, a large group of 820 posterior fossa ependymomas, looking at molecular subgroups and just demonstrating that if we leave significant tumor behind in these PFA cases, that they will not respond to radiation or chemotherapy in most cases and have a horrible prognosis. And so we typically will tell the family up front, we'll get as much as we can, but don't be surprised if we have to come back for a second operation to get the rest of it out. We always routinely planned to get a postoperative MRI the morning after surgery and have OR time prepared if we needed to bring them back. Now that we have the intraoperative MRI, it obviates a second operation because we can do that scan before we close on the same day. But a third of our children in our series had to go back for return to surgery because of residual tumor in the days before we had the intraoperative MRI. In terms of the genetic landscape of these tumors, again, we've got the change in nomenclature from the C11 orpha to the zinc finger nomenclature. We've got the change of the myxopapillary ependymomas to a grade 2 tumor, as you see here. And keep in mind that the subependymomas are typically adult cases. The last one I operated on was a 38-year-old policeman. And then this paper from David Ellison and others looked at the PFA ependymomas and their molecular profile and demonstrated two major subgroups of PFA tumors and 9 minor subtypes of PFA ependymomas. And you can see quite clearly here the consensus clustering between the two groups, and then the molecular abnormalities and how it relates to prognosis in these 9 different subtypes. And I'll make the point that although this is important information, if you consider trying to construct a prospective randomized multi-center trial for these tumors, there is no way that as we approach personalized medicine that you can construct a study that will allow you to gain enough patients in any one group to use statistics or to determine long-term outcomes. So we now have to look at other modalities if we're going to study these tumors with this many different abnormalities. Naren was nice enough to forward me a new paper by Michael Taylor and by Eric Holland, who's in Seattle, identifying yet 2 more molecular subgroups for ependymomas. Again, not really clinically relevant, but with new monoclonal antibody therapies coming into view, this may become more important in the future. This is a case of a teenager who came to us. She was having dizzy spells, otherwise neurologically normal. Her dad was a physician and got her scanned and was found to have this ependymoma at the obex, and we can tell on this preoperative MRI that's invading the brainstem right at the obex. So the way we approach these is to resect the arachnoid. Here you can see the tumor. This is the cerebellum up here, spinal cord down here. And we want to start out at the below the tumor. We put gel foam down to prevent any spread, as I mentioned before. Then freeing up what we can easily of the tumor capsule, freeing it up from the pia of the spinal cord, trying to find the vermian branches of pica bilaterally because we know that's where the blood supply is going to be to the tumor. We want to send a big chunk of the tumor to the pathologist so they'll have plenty of tissue to work on. And then work around the tumor, trying not to manipulate. You can see the vermian branch here, taking the feeding vessels as they come off. This is on the other side, but trying to leave the vermian branch intact if we can. Then looking up above the tumor and getting gel foam up above so that we don't have blood and tumor tissue go up the aqueduct. And then working around, just gently debulking the tumor, trying not to manipulate the tumor much because when we do, we manipulate the brainstem, and we don't want to cause a floor of the fourth syndrome by manipulating the tumor. Once we've worked all the way around it, then we can turn the power down on our bipolar and using the ultrasonic aspirator, try to get it away from the ependymoma. These tumors will cause neoplastic vessels to grow straight up out of the brainstem, and we don't want to chase them down into the brainstem if possible, but we want to try to get as much tumor away as we can. And you can see this little thin carpet here that's left behind. And so I'll make the point that when we as surgeons are operating under the microscope, nowadays it's possible that we can see that we've left a small amount of residual tumor behind that the radiologist may not be able to define on postoperative imaging. And so it's important that we list that in our operative report, that it's not a gross total resection. We know we left some residual tumor behind, even if the radiologist postoperative scan says that there's no evidence of residual disease. So she had no 1Q gain. She had a diffuse H3K27 immunoreactivity, fairly typical of a PFB. And I'll close with this paper that Tom Merchant published a couple of years ago. And the exciting thing about this paper is that these two medical students who collected the data, Gabby Howe and Grace Dirks, were both children that we operated on for their posterior fossa tumors who are now in medical school and interested in careers in pediatric neuro-oncology, studying their own disease. We had 101 children, less than 3 years old. Median age at surgery or diagnosis was 2.1 years, but almost 20 years of follow-up in this cohort. And as I mentioned, 31% had more than one operation, but we had a gross total resection in 82%, near total in the rest. We had one patient that had more than 1.5 cc's of residual tumor going into treatment. The rest of them had near total resection or gross total resection. And their 10-year event-free survival was 58.5%. Overall survival, 72%. 34 of the children died from progressive disease. 6 died from secondary neoplasia, most likely from their radiation. 2 died of radiation necrosis, 1 of a shunt malfunction, 1 of anaphylaxis. But at 25 years, we only had 1 patient lost to follow-up, which is one of the beauties of the St. Jude system. When we look at their functional outcomes, 98% had a high school diploma, 89% are students or have a job, 70% went on to higher education, 64% had a driver's license, and a third are living independently. So when we take an aggressive approach to these children, we limit the radiation to the tumor bed. We can have very high quality functioning children in survival. So in conclusion, the majority of childhood ependymomas at the moment, what we as neurosurgeons can do intraoperatively remains the most important predictor of survival. Chemotherapy is useful for very vascular tumors, allowing us a second look surgery, trying to get more tumor out safely when we need to. And it's important that we counsel the families up front that if a postoperative MRI shows significant residual disease, localized disease, that we will plan to take the children back to surgery for further resection. So thank you very much, Naren. I'll turn the podium over to Jason.
Thank you, Dr. Boop. That was a fantastic lecture, really very insightful, and thank you very much. I think if that's okay with Jason, I think we will discuss your lecture, Dr. Boop, before we going. It's always good to discuss when it's hot. So please post any questions on the chat box. But in the meantime, I'm going to invite Dr. Elias Risk, who is one of our faculties. Thank you very much for joining us, Dr. Risk. He's a professor of pediatric neurosurgery at University of Texas at Austin. Elias, do you have any questions or comments?
I think that's very insightful. Thank you, Dr. Boop. That's a deep dive into ependymomas, and we took for granted, the simplification of the grading system. But you, as anybody else knows in this room, they're extremely complicated, and those cases are not similar in any way. So a lot of understanding of genetics is necessary as a neurosurgeon going to tumor boards nowadays to really be educated to try to help your patients as much as possible. So it's not just ependymoma, like you said, it's lots of nuances, and the addition of that information regarding chemotherapy, adding some element of a second look surgery to help improve prognosis is going to help a lot of patients.
Thank you.
Thank you.
Thanks, Dr. Risk. Dr. Mukherji, can I please invite you to for your comments and any questions for Dr. Boop, please? Thanks.
I think it's terrific. Obviously, it's an honor to hear that lecture. What was interesting to me when you were giving your presentation was, for myself, I hate to say this, I trained in the last century and I was born in the last century, and I still remember doing myelograms when we were working up patients with posterior fossa tumors. I don't know if anybody hears of that vintage. And then I was at the Brigham when we first gave gadolinium. So at that time, Peter Black was the chair. And
Right.
What is interesting to me, and I'd like your comments on this, is when we first came out with MR, it was really revolutionary because we could see so much of these tumors that we would see indirectly. And in general, the brain MRs that we do, even if we're doing it at 1.5 Tesla or 3 Tesla, or even now a lot of places doing 7 Tesla, they tend to be regular standard sequences. And we as radiologists can make the diagnosis as easy as neurosurgeons and neuropathologists can. But there's a lot of emphasis now in imaging regarding radiomics, radiogenomics, and some of the predictors. But my point number one is when I hear you talk about this, it seems there are not a lot of treatment options when it comes to many of these ependymomas. The primary treatment tends to be surgery as opposed to other modalities. And where I'm going with this is that as a radiologist, there's a lot of headwind or a lot of tailwinds to do a lot of the molecular imaging, which is incredibly important. But when I saw these beautiful surgical resections, a lot of the outcome is based on how much of the tumor that you can resect at the initial resection. And what I would like to emphasize to this group, and I'd like your opinion on this too, is with me being a head, neck, and skull-based radiologist, we really try to emphasize looking at every single nerve, looking at every single piece of anatomy that we can see. So I would just like to emphasize is that if you are taking care of these patients, especially when these tumors are associated with the intricacies of the brainstem, is try to, yes, do all the more biological imaging, but also optimize your imaging acquisitions such that you're doing single millimeter, 2 millimeters thick sections, and for the radiologist to work with you to provide a checklist or provide key elements in their reports that you need to know to better counsel the patient and plan your surgery to try to obtain as much gross total resection as you can.
Yeah, I think that it points to the requirement that patients like this be managed at referral centers where we have pediatric experts and not adult neuroradiologists trying to give us interpretations and things like that.
Thank you, Dr. Mukherji. There's a question for Dr. Boop from Dr. Suarez. What would you recommend to us, like the young neurosurgeons, where we do not have adjuvant therapy in hand for ependymoma?
I think forums like this are leveling the playing field between neurosurgeons around the world. I think that children like this need to be treated at referral centers, specialty centers, particularly if they're seeing a neurosurgeon that is young and fresh out of training. And I think it's good for neurosurgeons to be able to take a day and go scrub with an experienced neurosurgeon or invite a senior partner to help them take care of these kids until they've done a few and they get more experience, because this really is a life and death situation for these children based upon the quality of the surgery that they're getting up front. And the first time is the best time to give them a chance for a cure.
Thank you, Dr. Boop. Dr. Chiang, do you have questions for Dr. Boop from a neuropathologist point of view? Thanks.
Not really a question, but I learned a lot from Dr. Boop's lecture as always. It is very nice to see from a neurosurgeon's perspective, especially those intraoperative videos. I usually don't get to see those, so I really appreciate that. And one thing that I would like to say is regarding the histologic grading of ependymoma. Over the years, I've seen people using different criterias and different counting methods for grading of ependymoma. That's why Dr. Ellison had the negative study quite a few years ago. What I am hoping to do or achieve with the new molecular information, new molecular era, and the prospective trials at St. Jude is that to see if we can refine those criteria or finding the true criteria that actually matter in light of the molecular information, PFA, PFB, surgery, and radiation in a more consistent way. Because from our own St. Jude cohort, there are actually some factors that might associate with outcome. For example, increased mitotic activity for posterior facet ependymoma, increased infiltration for supratentorial ependymoma. I'm hoping to support that, or at least to know better the situation with prospective trials. So I hope the next generation of our ependymoma trial can include those, so we can set that question. Because right now in the WHO, grading is needed, but there is no defined criteria, which basically give us a situation that we don't know what to do. So I think those are still unanswered questions.
Your thoughts, Dr. Boop?
No, I'm ready to hear Jason.
Okay, thanks. Professor, you have lots of questions from me, Dr. Boop. So, Professor Goel, your talk, your comments and questions to Dr. Boop. Thanks.
No question. This is high quality stuff regarding ependymomas. Most beautiful thing that I liked about this presentation was the patient with hyperextension of the neck in a case of ependymoma, and how Professor Boop managed it. You see, what the thing is, when there was a tumor, this boy went into hyperextension. So this hyperextension was a protective natural phenomenon. Like you have a disc, the person goes in a scoliosis. So that scoliosis is a natural protective phenomenon. You have torticollis when there is atlantoaxial instability, and a lot of deformities that we think that they are deformities actually are natural protective phenomena. That is what a beautiful message I got from this lecture. And how that deformity, you see, you have a natural deformity and you try to protect and turn it during operation by making the head flexed. You could have killed the patient before you have started the operation. So I think the way you handled it and the way you handled that extreme hyperextension position was one beautiful message that you have given. And also a message that you have given is that deformities are secondary, deformities are protected. We have to find out why there is a deformity. You have to treat that why rather than the deformity. So this is one beautiful message, Fred, you have given in this lecture for me.
Thank you. Thank you very much, Professor Goel. I remember, you might not remember, but 25 years ago, I was in Pune. You gave the lecture before me at the neurotrauma meeting, and I came after you, and you were mentioning the same thing, the idea of the midline shift on the head, and rather than aiming at that one, the midline shift, what you want to make sure is decrease the pressure and understand the deformity. So the theme for 25 years has been there. Thank you, Professor Goel. Thank you very much. Dr. Boop, I have a few questions for you. So I will start with the first one. In terms of, you mentioned that if it's a 30 patients with pediatric brain tumors, you are looking at around 3 tumors with ependymoma. Do you have any view on how many ependymoma, a surgeon who operates on ependymoma, how many should he operate in a year, or the 30 operations in the pediatric brain tumor is good enough for the 3 ependymomas per year? Thanks.
Yeah, I think experience matters, Naren, and working with more experienced colleagues is important. If a children's hospital has 4 neurosurgeons on faculty and they get 3 ependymomas per year, that means oftentimes a neurosurgeon doesn't see even 1 a year of these. And so in terms of treatment at specialty referral centers, I think it's important for these tumors. It's important for medulloblastomas, probably not as important for medulloblastomas, but for craniopharyngiomas, Atul can attest to the fact that patients being sent to referral centers where people do have experience makes a huge difference in the survival and the outcome of those children. So not everyone has the luxury of sending patients off, depending on the social situation and who pays for their care. They may have to do the best they can under the situation, under the circumstances.
Thanks. Professor Goel, do you want to come in? Regarding the experience for complex tumors, volume, how important is the volume?
Yes, there is no question the volumes are so important. And that is the reason I think working in a public institution, working in an academic institution is so important to get that volume, to get that complexity of the cases, to get, make your own design more than any. You see, I have worked in the academic institution all my life. And my feeling is, and my complete firm opinion is, more the numbers, more the complexities, is more important to develop a concept. And I think what Fred is saying, there is no question. You cannot do complex neurosurgery by operating once or twice a year. You have to be in it all the time to have an advantage of experience, advantage of controlling bleeding, advantage of having the knack of dissection, and all the things. You see, even what Fred said about the neck position, this has come from his experience. It is not just, by the way that he understood the issue of neck extension and that it is important to treat that extension before you actually operate. So it is experience, it is volume, it is your interest in the field and your commitment to the subject. All these things are so critically important.
Thank you, Professor Goel. Thank you very much. Professor Dr. Suresh Mukherji mentioned this, and when a tumor is on the cranial nerve, at what point, how you mentioned take the tumor from the nerve rather than the nerve from the tumor. Do you have any are you using your neurophysiology to find the nerves? Any tips and tricks and do's and don'ts and when to stop? Thanks.
Yeah. Well, typically the nerves are displaced by the tumor capsule and they may be stuck to the tumor capsule. And for me, we dissect the cranial nerves carefully using sharp dissection, either with an 11-blade knife or with sharp microscissors, rather than just taking a dissector and trying to push them away from the capsule, because that stretches and distorts the tumors and it damages them. So it's back to what Atul was saying about experience. When we started doing these big CP angle ependymomas 20 years ago, 30% of our children had a trach and a G-tube postoperatively. But nowadays, in the last 5 years, we've had 1 or 2 patients that had a feeding gastrostomy because they couldn't swallow, and it's unusual for them to require a trach. The last one we had to give a tracheostomy to was because he developed sleep apnea, central sleep apnea, and had to be on a ventilator at night because he would stop breathing. But learning how to respect the cranial nerves is part of the experience.
Thank you. I don't know whether I got it right or wrong. From about 10 years ago, was there a time that a policy for sacrificing cranial nerves if there's tumor ever practiced, or it was never that was never a philosophy?
Well, back in the 1990s, I think a lot of these kids with the big lateral ependymomas didn't get a very good resection. And if they did, they didn't have a very good outcome. So we've made a lot of progress in our current era compared to those days.
Thank you. Dr. Resk, do you want to come in, please? Thanks.
I just want to emphasize the point that Dr. Boop, reflected on with experience and having 4 hands in surgery. That's extremely helpful and helps patients' outcome. And we know that not just from neurosurgery, but also general surgery with breast cancer surgery. There's a lot of data showing that the experience improves outcome in patients from a surgical standpoint. So learning from our colleagues and knowing that data is very, very helpful. It's not a knock on ego, as you're going and trying to help patients and get the best outcome. Having 4 experienced hands is way, way better than one person taking care of these challenging tumors.
Thank you. Dr. Boop, I was going to ask on what Dr. Elias mentioned about the 2-surgeon philosophy. Could you just explain to us what do you mean by 2-surgeon philosophy? Is this 2 of you operating simultaneously, or one senior surgeon assisting? I know that skull base has the same. Thanks.
Right. Well, if you look at historically, if you look at the neurosurgical microscope, the assistant's ocular is 30 degrees off of the main surgeon's ocular. So if you've got an assistant who's looking through the assistant's ocular, they're having to stand sideways to look in, and they may be able to reach with one arm and provide minimal assistance, but otherwise the main surgeon does 95% of the operation. But by having two opposing oculars 180 degrees off for someone who's in the prone position, it's very comfortable. And you've got two neurosurgeons each using two hands. So one can retract while the other dissects, one can, and the other can, you can go back and forth doing that. For me, in training fellows and residents, it's a great way because if they're about to do something that I'm afraid of, I can grab their instrument with my forceps and stop them before something happens. And when you've got bleeding and you're trying to control the bleeding, you've got two people with suckers and bipolars that are retracting and sucking at the same time. So I think there are advantages to it once you get comfortable with it. It doesn't work well for the retrosigmoid position because that means the opposing ocular is having to look up and over the head to see what the seated surgeon is seeing. But for midline posterior fossa and spinal pathologies, it's a very comfortable operating position.
Thank you very much. Thank you. The other question is in terms of the intraoperative MRI. Has that changed the outcomes, the intraoperative MRI? Is there any studies that the intraoperative MRI have improved outcomes, or is it that it has improved efficiency, or taking the patient as you did before, again for the MRI second day?
We got our intraoperative MRI in 2013, and when we looked at the year before that, 15% of our brain tumor children overall had to go back for a second operation the next day. That means they spend the night in the ICU, they get sedated for an MRI the next morning, they have residual disease, they go straight from the MRI up to the operating room, have to have a redo craniotomy, and then go back to the ICU. The first year we had the intraoperative MRI, that number dropped to 2%, and the second year it dropped to 1%. So I think it saves children having to have a second operation. It makes us sleep better at night knowing what's inside their head when they're in the ICU postoperatively. Not that they can't have postoperative complications, but we've got a good idea of what their brain looked like when they were waking up and going to the ICU.
Thank you. The last question is, you mentioned about taking the tumor from near to the brainstem and being judicious about it and leaving a carpet when needs be. Is there any tips or advice on how to make that judgment, when to leave it, when to try to take it? Thanks.
Yeah, I think my best advice is don't chase tumor down into the brainstem. If you can get it to dissect away from the ependymoma, those neoplastic vessels come straight through the ependymoma up out of the brainstem, and you don't want to tear those and have them retract and bleed in the brainstem. But you also don't want a bipolar on the floor of the fourth ventricle. If you do, it should be very carefully with the voltage turned down. Otherwise, generally, we'll just put some gelphone and thrombin on them and irrigate, be patient, and try to let those microvessels stop bleeding on their own.
That's brilliant. Thank you very much, Dr. Boop. I will ask, there's one question. There's Dr. Suresh. So she has posted a question. My other question is, if I can see more of your video, most of the cases have forehand technique, like 2 bipolars and 2 suctions. I don't quite understand that question.
Yes, that's the essence of the forehand technique.
Brilliant. Thanks. Thank you very much. Dr. Mukherji, do you have any last comments?
Nope, nothing from my standpoint. I'm looking forward to Jason's talk.
Excellent, thanks. Professor Goel, any comments?
Yeah, I wanted to make a smallish little comment, particularly in reference to tumors like ependymoma, and particularly in reference to the relationship with the brainstem, and in the relationship of lower cranial nerves in particular. You see, trying to dissect is good. Trying to resect is good. But trying to take risk is not such a great idea. You see, what I nowadays do, particularly in cases of meningioma in this region, if I have to dissect for more than 3 or 4 minutes around a lower cranial nerve, I will leave the tumor behind. If I have to dissect more than 3 or 4 minutes around a perforator, I will certainly leave that tumor behind. My question is, radical resection is good, radical resection is important, but radical leaving small little bits here and there, particularly in your journey to save the function of cranial nerve, particularly, I will say, don't take too much risk with the brainstem. If you have to leave some tumor, that is not such a bad idea. And chances of recurrence, when we say recurrence is higher when we leave tumor behind, this is what the message also I got with Fred's lecture. See, recurrence is higher when you leave tumor behind, all right, but you leave tumor behind when the tumor itself is some kind of invasive tumor, when the tumor by itself is a bad tumor. And when you leave this bad tumor behind, the chance of recurrence becomes larger. So, we have to be as more the experience, more the ease of handling, and I will say additionally, more the ease of leaving some tumor behind in more critical areas. That learning process and that understanding process has to come with continued experience in the field. This is my feeling.
Thanks. Thank you, Professor Goel. Professor Dr. Boop.
Yeah, I think the important concept is if you leave tumor behind, chemotherapy and radiation therapy is not going to make that tumor go away. If we have a child where we can get the tumor out and we can give radiation, we can prevent the tumor from growing back. But to think that you're going to make residual tumor go away by giving radiation is, in most instances, faulty reasoning.
Thanks. Thank you very much, Dr. Boop, for this excellent lecture and for taking all the questions. I'm very grateful, and I will make the lecture available on the YouTube as well soon. Thank you very much, sir. So now this brings us to Dr. Jason Chiang for us to give us a lecture on molecular biology techniques, on DNA sequencing, on what is methylation profiling. I think Dr. Risk mentioned in his comment that when you go to these tumor MDTs or tumor boards, as they call in states, very quickly, at least I have found that all these genes come, and neurosurgeons are either, I certainly get find what's once the neuro-oncologist and radiologist and oncologist start to talk about all the molecular biology, either you nod on and say as though you think that you know what they are talking about, or unlike me, you just look, oh dear, what's happening now. So I think it's important for us to understand the basics of the molecular biology, so that we are on the table and we understand what others are talking, and we can also repost accordingly. So that's why I have been very keen to learn molecular biology, but nothing better than to learn from someone who really knows. So thank you, Dr. Chiang. Very much looking forward to your lecture. Dr. Chiang is a neuropathologist at the famed St. Jude Research Children's Hospital. Thank you for your time, sir. Thank you. You should be able to share it. Hello, Jason.
I just want to comment, Naren, that thank you for putting up that document summarizing those molecular genetics. It's you've done a lot of work to distill it to a very elegant way. So thank you very much.
Thanks. Thank you very much. Because sometimes you can come to these lectures and very quickly, once the genes come, get lost. But once you know the terms, and you can follow the lectures. I think it was part for everyone and part for me as well. So I'm glad that you liked it. And Dr.
Thank you.
Chiang, thank you very much. Dr. Chiang, thank you very much. Dr.
Yeah,
Chiang?
sorry, my connection dropped a bit. Now I came back. Before I start my talk, I just want to say I really appreciate how our neurosurgeons do for our patient. I always tell people, our neurosurgeons are the most important factor in the treatment of pediatric brain tumor, especially for ependymomas. That's the single most important prognostic factor is who your neurosurgeon is. I think I really appreciate what you do. So let me share my screen. I hope people can see my screen and hear me well.
Yes.
So this is going to be quite technical as Naren introduced, but I try to keep it down to things that you really need to know, the most important thing to help you make the decision rather than going into the nitty-gritty technical details. So we focus on DNA sequencing and DNA methylation profiling in this short 15 minutes talk. It's very short, so I'm trying to go into concise down to the most critical information. So here are our learning objectives. We try to understand the principles of common DNA sequencing platforms. We try to appreciate the key approaches we used to identify DNA methylation and to do DNA methylation profiling. And we try to compare the different strengths and techniques, and we understand their limitations. So I think this audience doesn't need an introduction for DNA, but the important things to know that there are four nucleotides: the adenine, the thymine, the guanine, the cytosine. They look different. They have different size and shape, and they have different binding preferences, like 2 hydrogen bond or 3 hydrogen bond. So those will be the basis for DNA sequencing. And the problem here we try to achieve is that we want to identify pathogenic variants, and they come in different sizes and magnitude. For example, there can be only change in one single nucleotide, a single nucleotide variant, or there can be deletions or insertions or variable sizes, can be just a few nucleotide or can be mega base big. And we try to resolve, are there any chromosomal translocations? Some of those could create new fusion genes, the ZFTA relay fusion gene, for example, for supratentorial ependymoma. And we try to resolve large-scale chromosomal DNA level changes like 1q gain, 6q loss, or in this case, a very complex chromosome pattern from a tumor. So our sequencing technologies, it's not one size fit all. We have to pick the question and then pick the technology that can answer this question. We have to keep that in mind. So DNA sequencing for clinical use, it's really wide. We almost cannot do without molecular analysis for neuropathology nowadays. We use DNA sequencing for cancer diagnosis and monitoring. We want to see if there are any targets for targeted therapy. The minimal residual disease, the concept is from lymphoma leukemia, but now we try to do this with the CSF for medulloblastoma, for example, and other brain tumors. And we can see if the mutations are germline, inherited or not. We can do pharmacogenetics to guide drug dosing with genetic variants in the drug metabolizing enzymes. And we can also do infectious disease for pathogen identification or outline or outbreak tracing. We all just came out of the COVID-19 pandemic, so I'm sure we all know about this very well. So let's go to some of the technical details of important DNA sequencing technologies. The most well-known is the Sanger sequencing methods. It's very simple. It uses the chain termination dideoxynucleotide incorporation for DNA sequencing. Basically, there's a polymerase to replicate the DNA, and it stops at random locations based on the different fluorescence labeled dideoxynucleotide. So we create length different length of fragments labeled by specific termination site of different color. Then we run a fluorescence, we run electrophoresis, and then we basically read along the length of the DNA of the fluorescence lane to see that's ATGC. We basically just read the sequence out of the fluorescence. It's really accurate. The polymers can go really long depending on how long your DNA molecule is. It's compatible with FFPE, so very clinical use friendly. The turnaround time is relatively quick. The problem is it's quite intensive, low throughput. It basically sequence one single gene at a time. Imagine you have a full panel of 500 genes, then that's impossible to do with this technology. But it's because it's really accurate, we can use this for small gene screening or use for this for validation. And next comes the big guns, the whole exome sequencing. Here we basically enrich the exomes by capture them and amplify them, and then sequencing them by the Illumina technology. Basically, it's not chain termination. It's just by sequential addition of fluorescence labeled nucleotide. And then we take a picture of every nucleotide incorporation. And we can do this for massive amount of DNA pieces at the same time. So it's called a massive parallel sequencing. And we just it's basically just repeat incorporation of a new nucleotide, take a picture, incorporation of a new nucleotide, take a picture, repeat. And by this, we can sequence massive amount of DNA at the same time. So it's really fast and broad variant discovery, relatively cheap, and it's FAP compatible. And the turnaround time, unfortunately, is longer just because of the massive amount of data that we have to analyze afterwards. And whole genome sequencing is really no-brainer. You sequence the whole genome, basically. You create a shotgun library, you sequence as the whole exome sequencing using Illumina technology, massive parallel sequencing, and then you assemble the genome by their overlapping sequences. So it's computationally intensive, it's comprehensive, it's more expensive, and it takes a really long time, 6 weeks to 3 months to finish the analysis. And targeted panel sequencing has become our favorite for clinical use for some time. It's a pre-selected panel, so it's not as extensive as whole exome sequencing or whole genome sequencing. It's cost effective most of the time because most of the gene mutations are within the selected panels. You can basically pick the panels you want, focus on the genes you want. It's compatible with FFPE and turnaround time is relatively quick, 1 to 3 weeks. And the inherited limitation is you can only see what you want to see. There is no novel discovery. And next is the new technology, the Oxford nanopore sequencing. It's different from the sequencing by synthesis. Basically, it has a pore on the membrane with a polarized membrane. And basically, there's a motor protein pull the DNA molecule through the pore at the same time as other ions passing through the pore, in this case, the potassium ion. And because of the bases have different sizes and shapes, it will change the frequency and the velocity of the potassium ion going through the pore. So it creates a difference in the current. So the algorithm can infer the DNA sequence through the changes of the current. And because the pore motor protein can really keep going, pull the DNA sequence along the pore, so it can do ultra long read sequencing, more than 100 kilobase pair. And it's direct detection of modified bases. So it's not just DNA sequencing, we can detect DNA methylation as well. The device is relatively small, it's real time, and the real advantage is that it's really fast. You can finish the sequencing analysis within hours, sometimes when the patient is still on the table in the OR. So it's really amazing. The downside is that it's really new technology, it's more expensive, and has a higher error rate, but things are improving nowadays, especially with the new hardware and software in 2025. And the other sequencing technology that we have is the nanopore technology. It's a single molecule sequencing technology. Basically, you trap a single DNA molecule and one single DNA polymerase in a flow well. And basically, it just go round and round, keep sequencing this. And the DNA molecule can be really long, so it's really accurate because you basically just go round and round sequencing the same DNA molecule many times. And the turnaround time is relatively quick, like 10 days. The cost is slightly higher, but the accuracy rate is really high. So this is the technology of my preference right now if I want to do long read sequencing for my research. So here's a table for technology comparison. It goes from one single gene all the way to whole genome, different technologies of the long read sequencing and different turnaround time. So nanopore shines here by its really short turnaround time, although the error rate is disadvantaged. But I hope things will improve in the future. The low throughput technology like Sanger sequencing, the error rate is really low. So you really have to find your question to find the best to use and pick the technology that can answer the question you want to answer. Now we'll switch to DNA methylation. So why do we care about DNA methylation? There are many different flavors for DNA methylation. It's basically just a modification of the DNA basis, the nucleotide, addition of the methyl group on the DNA molecule. We primarily focus on CpG methylation. There are many different flavors, but for this talk, we focus on CpG methylation. Why it is important? Because it can modulate gene expression. It's an epigenetic mark that changes when the cell differentiate or change the cell's fate or decision without changing the DNA sequence. So we can have the same DNA sequence in every single cell of our body, but they have different epigenetic marks. That's why they express different genes, they express different functions, they have different repertoires of transcriptome program. That's the power of DNA methylation, and that's the power that we use DNA methylation for things like tumor classification because they carry the epigenetic signature. So the clinical use for DNA methylation is actually tumor classification. We don't actually look at the DNA methylation itself, but we use the ensemble profile or signature of DNA methylation, trying to tell what this tumor is. And by the technology of the methylation array, we can also get DNA copy number profile information as well. So basically, you get two information out of the same methylation array. You get DNA methylation for tumor profiling, for tumor classification, and you also get copy number variation to tell 1q gain, 6q loss for ependymoma, for example, CDK2 homozygous deletion, for gradient of IDH tumors or polymorphic xanthoastrocytoma, for example. And sometimes we do look at DNA methylation directly because it changes with the diagnosis or prognosis for RB1 genes, for example, for retinoblastoma or for MGMT to guide the use of temozolomide. So here is a copy number plot from the DNA methylation profiling just to show how it can show the gains, amplifications, or losses of specific chromosome segment or specific genes. So the basic principle of DNA methylation profiling is bisulfite sequencing. This is the most widely used, where we use chemical reaction to change the methylated cytosine, unmethylated cytosine to uracil. And the methylated cytosine is basically protected. And after the PCR reaction, the unmethylated cytosine became uracil and then becomes a thymine. And then we sequence the DNA, the PCR amplified DNA fragments. And then we compare this modified DNA sequence with the reference genome. So we can tell where is the methylated C that is unchanged, or where is the unmethylated cytosine that has been changed. And this can do on a single gene level or whole genome bisulfite sequencing, the whole genome level, and it's FFPE compatible. The problem is it's a harsh chemical treatment. We need a relatively high DNA content, high DNA input to achieve the DNA methylation profiling. So the new technology is to use enzymes to achieve the same chemical reaction to change the unmethylated cytosine into uracil, into thymine, and to protect the methylated cytosine to make it unchanged. And with the same principle, just use enzyme instead of bisulfite sequencing. It's a newer technology. It's slightly more expensive, but this is the preferred technology for doing DNA methylation sequencing right now, at least for my research application. And here is the very famous DNA methylation array by Illumina. It uses bisulfite conversion technology, but instead of directly sequencing the whole piece, it uses different probes, the clever probe design to tell whether the specific CpG site is methylated or not by incorporating fluorescent labeled nucleotide with different channel green and red at the different positions on the array. And one array can take 8 samples and one instrument can take 2 arrays. So we can run 16 samples at the same time. And the array has improved over the years from 27K to now over than 1900K probes. The turnaround time is relatively fast, 1 week. It's FFPE compatible. The limitation is that it's array-based. I only probe around 3% of all the CpG sites in our genome, but these CpG sites are hand-picked to focus on important regulatory regions and regulatory CpG sites. So although it probes only 3%, that's the important 3%. So the methylation array is quite useful most of the time for clinical and research. And we all know that the DNA methylation profiling is really groundbreaking. It changes our practice in neuropathology. It changes how we classify brain tumors. And it is actually incorporated into our current edition of the WHO. Here you can see on the high dimension reduction plots where we can plot the DNA, the tumor into specific tumor types based on their DNA methylation profile. So this can be used for diagnosis, can be used for prognosis, can be used for in not so suboptimal samples, or can be used for very difficult situations where we cannot tell the tumor type by histology. So that's the power of the DNA methylation profiling for brain tumor diagnosis. And the way we tell tumor type is we can train artificial algorithm and machine learning algorithm with a DNA methylation profile with curated labeled data set to classify these tumors. And you can pick your favorite algorithm. For example, the neural network, it simulates how our brain identify objects. You have input layer of neurons and different middle layer of neurons and with the output layer of neurons with a label data set to tell, oh, this is a PFA, this is a PFB with the output, single output and with a confidence level. Or you can use the random forest methods where you have many decision trees with the decision branches with specific probes, and you have many of these trees, like 10,000 here, and then we take a majority vote. Like, oh, most of the trees think this is PFA. Then we have a higher confidence for PFA, for example. And these two methods, they work pretty much equally well. And like we like to have multiple pathologists to have second opinions on the tumor, so we have higher confidence regarding diagnosis. It is also very important that we have multiple different versions of different classifiers from different institutions, and we use them collectively to give us a better confidence for tumor classification. And as I said earlier, the nanopore technology can also be used for DNA methylation profiling, and the turnaround time is really quick. Although the read accuracy is lower, that's something we need to keep in mind. So here is a table for technology comparison from the DNA methylation array to the enzyme-based sequencing, bisulfite sequencing, whole genome bisulfite sequencing, nanopore, different turnaround time. So we really need to pick the best use situation to fit and pick the technology to fit the question that we want to answer. So this is very important that we have a basic understanding of this technology so we can use them in the optimal way. So the take-home message here is that we need to balance the throughput, the cost, the resolution, the turnaround time, and the application for these technologies. And the short read NGS and long read NGS, they have their advantages and disadvantages. And the array-based DNA methylation profiling and the sequencing-based DNA methylation profiling, they also have their advantages and disadvantages. And there's no single technology fits all. We have to match the question to the appropriate platform. And the best thing to do is we oftentimes in big centers, we have multiple technologies that we can choose. So it is important to integrate all the information complementary methods we have. And in addition to molecular pathology, we also have histology, we also have conventional immunohistochemistry. So we put everything together and also neuroradiology information. So we put everything together, we see the disease as a whole, then we can make the best diagnosis and prognostication and treatment decision for the patient. So this concludes my presentation. Thank you all again for the opportunity to speak, and I'm happy to take any questions you may have.
Thank you very much, Dr. Chiang. That was fantastic lecture, giving us a outline of the important sequencing and methylation profiling techniques, and those tables are very useful. And this is the first lecture that I have ever heard on this subject myself. I think I know that as surgeons, most important thing is to cut, but I think we have to be very well versed in these fundamentals as well. When then only we can make intelligent decisions and also have intelligent conversations and not become technicians in managing brain tumors. This is not my thoughts, but this was Professor Andre Groton, who told me 10 years ago. First of all, I'll go to Dr. Boop. Dr. Boop, your comments and questions for Dr. Chiang. Thanks.
Well, I agree, Jason. That was a beautiful presentation, and having your charts comparing one to the next is wonderful. So my question is, when I look back in time with immunohistochemistry, there were times where a specimen would come in that was labeled 1p19q positive, and you guys would test it and say it was negative, and I would say, why is yours different? And you would say, well, our quality control is better. And with this complex technology, quality control is essential. It's probably timely, and it probably takes a period of time for an individual pathology center to learn how to do the quality control for each one of these technologies. Can you just comment on how easy is it to learn to teach a new center how to do whole genome sequencing, for example? Does it take days or weeks or months?
Very good question, Dr. Boop. The quality control is actually not easy. Even for some cases, we struggle with that. And the quality control is not just limited to the quality of DNA, the quality of the RNA, and it's actually it starts from the OR, the quality of the sample. Oftentimes we have to do quality assessment, starting from the tissue, the fresh tissue, the FAPE tissue that we send to molecular pathology for sequencing or methylation profiling. So it's really a complete package, starting from tumor content assessment, tissue quality assessment, the quality of the DNA extracted, the quality of the RNA extracted, the quality of the library preparation, or the quality of hybridization, the quality of the sequencing. We build in many matrices along the way so that we can have a confidence, oh, this result is believable or that result is not believable. And before the technology is put into clinical use, we actually sequence or hybridize many of the cases that we know the molecular alteration already as the gold standard to validate the platform, to make sure the sensitivity to the specificity and to train the personnel within our institution. So it is actually not easy to train a person or to implement these technologies to a new center where people don't really have a lot of experience. So to compensate for that, I think part of our Senju global effort is actually to invite specialists, technologists, pathologists, clinicians from global institutions to Senju, really to see how we do it. And we also do site visits to go to their institutions to see how you do it, how things can be improved. And in many instances, the most practical way may not be to do things yourself, because if you don't see enough cases, you don't get enough volume to support the test, or you don't get enough experience, it might be better just like doing ependymoma or medulloblastoma surgeries. It's probably not best for every neurosurgeon to pick up the knife and do it. It's probably better to refer the patient to specialized center where experience and the technology levels are there that we can develop the optimal care for the patient.
Thank you, Dr. Chiang. Dr. Mukherji, can I bring you, please? Thanks. We are radiology and molecular biology and pathology cross.
Yeah, no, I don't want to emphasize what Dr. Boop said too, because if you will, outside in the real world, if you will, a lot of these patients are not getting operated at specialty centers. And part of my work is also in the health policy sphere. As we know, much more of the pathology right now, or the actual, what we think the tumor is actually comprised of, is really based on molecular and various biomarkers, if you will. And so now a lot of states are paying for biomarker testing, which is good, but you're having a lot of these independent centers pop up that are doing the biomarker testing. Now, it may not be as much for pediatric neuro-oncology, but overall, when we look at tumors as a whole, these for-profit centers are popping up, and you do run the risk of inaccurate results. And that could actually adversely affect patients, which is one thing. But then on the other hand, from a healthcare standpoint, you're spending millions and millions of dollars on some of the personalized treatments based on specific biomarkers. And if the information is incorrect, then not only is the patient not going to have a good outcome, but from a healthcare resource standpoint, those are resources that have not been used optimally. So I just want to compliment that comment that was made by Dr. Boop. Jason, my real question is, there is this growing field of radiomics and radiology and radiogenomics. And, from our standpoint, what radiomics is information on the imaging studies that we just can't see with the eye. So it's sort of embedded quantitative information. So I am curious, number one, to see if you are using radiogenomics. You're taking radiology information and you're using it for what we sometimes refer to as integrative diagnostics. But there is this whole concept of radiogenomics. So number one, are you using any type of these radiogenomics for prediction models, and are you making decisions off of it? And then finally, we sort of talked about this a year ago, and Naren used this great analogy where the goalposts, pathologists keep changing the goalposts. So every 5 years, a tumor that we thought of one thing is now changed. It's great for radiologists because, 10 years ago, we reported on the ZLA ependymomas. Now a whole host of papers are now coming off about ZFTA ependymomas. So we understand more that the terms change. And as a result, as a radiologist, I'm kind of curious to see, number one, how are you using radiogenomics? and how is this sort of changing with the way the advances are coming in molecular pathology and the information we know about radiogenomics now? Is that going to be still accurate 5 years from now?
Yeah, very, very good questions. Radiogenomics, yes, I'm using it, and I'm actually actively developing it by collaborating with our colleagues in the Department of Radiology and also AI specialists and scientists on this front. So how do I use it? Radiogenomics may sound like fancy, but actually we have been using it for a long time. For example, DIPGs. If you see a tumor in the pons with the typical imaging features for typical DIPG, we know 85% of the time it's diffuse midline glioma with H3K27M mutant. And another important example is medulloblastoma. For example, exactly midline tumors racing from the inferior femurs versus slightly of midline tumors versus cerebellar hemispheric tumors. We probably can guesstimate is the non-wind non-sonic hedgehog versus wind versus sonic hedgehog tumors. And in combination with the patient's age, you probably can have a guess even before we look at the slides to see, oh, is that really a medulloblastoma? If so, what kind? And we try to move forward through that front by combination with the methylation, tumor classification, and the molecular alterations of the tumors, V600E, BRAF fusion, BRAF mutation, for example, ZFTA, RELA, YAP1, and the radiology features by using AI and machine learning. And we do transfer learning by learning from adult tumors, which we have more data set because these algorithms are always data hungry. And we transfer learning to a smaller data set of pediatric brain tumors. We try to see if we can come up with something smart that can be useful as a companion for clinicians, for pathologists like me to make better diagnosis. And there are many examples out there already. I'm sure the field will move forward fast. Just you see how ChatGPT and Perplexity, these algorithms improved. It's really amazing speed. So I'm really looking forward to that. And regarding the changing classifications, yes, I think we are creating the problems for ourselves because we do research for brain tumors and we discover new subtypes, we discover new molecular markers for these subtypes. And the field is changing so fast that we have to keep up with the literature, and the WHO is almost outdated right away the time it's published. Like we used to call relay fused ependymoma, now it's ZFTA fused ependymoma, and now we have even more ependymoma subtypes. For example, ACVR1 mutant subtype, the posterior facile ependymoma is not even a WHO. We have other tumor types that are not even a WHO. So we try to classify the disease at the same time to correlate with the clinical features and with their treatment outcome. But then we are changing the disease classification. So basically, we are changing the label of the data set for training of algorithm. And at the same time, we are also doing clinical trials. We are changing the therapy for the change the classification, change the tumor type. So we are changing the outcome of the disease. So the goalpost is changing not just pathology, but the treatment side, the outcome side. So collectively, we just have to keep learning, keep improve ourselves, and we do this all for the good of for our patients. So I'm looking forward to the exciting future, although there is going to be an explosion of.
Thank you, Dr. Chiang. Dr. Boop, do you have any comments there?
I thought that was a brilliant point. If you look back in the history of medulloblastoma, once we changed the terminology and we started taking out the bad acting tumors where the kids all died, then the people with classic medulloblastomas had a better survival. So, yeah.
Thanks. And going back to what Dr. Boop said, when you are doing tractography, depending on who the physicist is, that the tracks can be different. Am I right in that, Dr. Mukherjee? And is that the same? Are we having the same issue with these methylation profiling? I think that's what Dr. Boop mentioned. If I take specimens from different labs to different lab, am I going to get a different? Am I going to definitely get the same results every time, or is it going to be different? About let's say PFA and PFB.
Yeah, very good question. Sorry, our internet dropped for a brief moment. So sorry if I misunderstood the question. So tumor classification by DNA methylation profiling, if done by methylation array, whether by FAP tissue or frozen tissue, is actually quite stable. That's the beauty of DNA methylation because the methylation mark is almost permanent. There is no easy way to remove the DNA methylation unless the base is excised and resynthesis. And it doesn't change easy with oxidation or pH change or other enzyme like fragile.
Naren, can you hear him?
Yeah, I can't hear. I think he's just dropped off, I think.
Yeah.
He'll be coming back. I'll just while we are there, I'll just post the yes. And once again, I just want to mention I'm not in ISBN, so I'm not in any way trying to say anything about ISBN. But Dr. Boop, can I just ask you to let the delegates here know about your ISBN library, because I find it very, very useful. Thanks.
Yeah, thank you, Naren. That's for those of you who don't know, for the last 3 or 4 years, the International Society for Pediatric Neurosurgery has invested heavily in a library, ISBN library, that is a repository for lectures, surgical videos, publications, and it's available through the ISPN website, which is ispneurosurgery.org, www.ispneurosurgery.org. The library is open to everyone, whether you're a member or not. It's free for families, free for physicians. And for those of us who lecture, it's great if we can donate our lectures to the library. Shlomi Constantini has staff in his office who maintain it and can help upload your talks so that they can become part of this library that's available to people like us anywhere in the world for free.
Thank you. I know I will definitely recommend, whether you are neurosurgeon or neuro-oncologist, to have a look at it. It is really good with all the best in the fields giving videos, and the videos are fantastic. And so I will definitely advise. Dr. Chang, great to have you back. Thank you, Dr. Boop, for that. And Dr. Chang, great to have you back. You were mentioning that the DNA methylation is pretty stable. Is that right?
Yeah, it's really stable across the institution, across the platform, and it's quite reproducible. So that's why it's widely used because we can actually use other people's file to do the profiling and to do the training. So that's the beauty of it.
Thank you. Dr. Elias Risk, your questions, comments to Dr. Chang? If Dr. Risk is not there, Professor Goel, do you have any questions, Prof. Goel?
Yeah, Naren, that was a very, I can see how the, 20 years or maybe 10 years ago, nothing like molecular studies was even discussed. And how the pathology has grown over the period of time, how the molecular profiling of tumors has grown and developed, how you can prognosticate the outcome, and how you can study the tumor biology. All these things very interesting. And I congratulate, for such a wonderful lecture. I'm really happy to hear a lot of new information, lot of novel thoughts, and my best wishes to you.
Thank you, Dr. Goel. And I know that ISBN runs pre-Congress meetings on various subjects. Maybe a molecular biology. I think they did it in South a few years ago. ABC molecular biology for neurosurgeons would be useful, because otherwise we will be cut out from this conversation, and then we'll start to lose our which is our tumors, our area. There's Dr. Mabel Banson has posted a question, and it's a question I was also going to ask. I read about the DNA methylation profiling, and I tried to understand it, and you made it clearer, much clearer for me. But I just wanted to clarify. By the time that the cytosine is made into uracil, and then it comes to thymine, and then is that DNA then chopped up by enzymes and then sequenced, and then the pattern is looked at, and that's what the methyl profiling, or have I got it wrong? Thanks.
Yeah, very good question. So yes, the DNA is actually sequenced. It's fragmented already. It's either intentional from fresh tissue or by the FP fixation is fragmented already, and then it we use bisulfite treatment to convert the unmethylated cytosine into uracil, and then with the PCR reaction to thymine further, and then we sequence that fragment and compare to the reference sequence. Sorry that I was not clear, but then after the PCR, the rest of the reaction is just like regular NGS.
Brilliant. Thank you very much. If Dr. Risk is there, but I don't know whether his internet has. Dr. A.S. Risk, do you have questions for or comment for Dr. Chiang? Thanks.
No, not really. I mean, this is like you emphasized, knowing this information will arm you with the best decision making, not just how Dr. Boop thinks about positioning and trying to tackle the surgical component, but also to have all the additional information. And at some point in the future, we're gonna have to make real-time decisions as we resect tumors based on the pathology. So you can't really fall behind the curve, as you said. And I thought you sent a recent article on intraoperative diagnosis from the group in the UK. So you can see how we are advancing exponentially, especially with AI, and the understanding of the data and literature is going to be making you a superior neurosurgeon and having to tackle patient outcomes in a much better way.
Thank you very much. I think you make a great comment that in 5 years' time, when we come back, neurosurgeons in the middle of theater has to absorb what the neuropathologist tells about the probability of it being a PFA or a PFB, or something more obscure, and then decide on what needs to be done. And the last question to Dr. Boop. Dr. Boop, where do you think we are going to be in 5 years? Let's not go for 10 years. In 5 years' time, thanks.
Well, there's no question that our knowledge is accelerating. And I predict that there will come a day where we don't take these tumors out anymore. We'll have a molecular understanding of their biology, and we'll have other ways of treating them. And it may be that we can get a molecular diagnosis from serum or CSF and save these children some of the big operations that my generation had to put them through.
Thank you very much. I think it's the sheer advance in the last 5 years is so fast. I think we'll have hopefully a lecture from Dr. Suresh Mukherji on AI and radiology, hopefully not too long, maybe just after the summer. But the sheer speed is so. I think I would just ask Dr. Mukherji to mention, because you are very versed with AI in your field. Dr. Mukherji, what's the speed of things changing?
Yeah, that's a great question. I think AI is everywhere, and radiology tends to be at the nexus of this. There've been over 1,000 FDA-approved devices for AI. 75% of those have been in radiology. I think in the future, everyone is going to be using artificial intelligence, but there are different types how AI is integrated into radiology. I think what gets the most attention is what we sometimes refer as pixel-based AI, where we use an AI algorithm and we evaluate an image and it kind of spits out a diagnosis. That's where the real focus is right now. I think right now, AI is not the future, it's the present, but I wouldn't characterize the current state of AI as disruptive, at least in the United States, because of FDA regulations. So I think it is the present. There are clearly ways. I use about 14 different types of AI algorithms through my various practices. Some are better than others. There still needs to be more validation because sometimes once you buy the AI algorithm, the diagnostic accuracy of the algorithm is based on how we present this to the FDA, because we need to show that it's as equivalent to a human. But once it actually gets out in your own practice, the data that you're being used is not the highly curated data that was being used when the algorithm and the product was first created. So my point is that once it actually gets into our practice, the results often are at times disappointing. But if it's purchased by a big institution, once you purchase something like this, it's part of your infrastructure. And I don't think there's enough attempt right now to validate the data on your own information. So my point is, I think it's the present, not the future. It's not necessarily disruptive yet. But as Jason sort of mentioned, with new techniques such as transfer learning and trying to have a little bit more cooperation, it's hard because each one of these companies have their own specific data sets. But more recently in Europe, I know one of the leaders in AI now can evaluate a chest CT with 124 different assessments. And I think that's where AI is going to in the future. So it's promising for sure.
Thanks. Thank you.
Can you give us a real life example, like, what the AI is doing in your practice?
Yeah, sure. And I'll try to be brief because we're right at time. When we look at the value chain of imaging and radiology, AI can be integrated to basically, as Jason mentioned, AI is predictive analytics. So we use various mathematics in order to predict what the outcome is going to be or what the data is showing. So we use AI for things like, is a patient going to show up in our schedule? Is a patient going to show up in our department? When we use AI in our equipment, which is really where the majority of practical AI is being used, you have a lot of different original equipment manufacturers like CTs and MRs that are using AI for dose reduction for CT to help improve the image quality for MRI. We use the things that I talked about earlier for pixel-based MRI, where it can detect nodules on chest CTs and chest X-rays. I use it when specifically if I'm dictating a report. So if I dictate a report and then they have AI algorithms looking at large language models and generative AI to actually automatically create an impression. And it's amazing how much time that saves, and that actually acts as a quality metric as well, too. And so those are just 4 areas that we use it on a daily basis.
Thank you.
Thank you very much, Dr. Mukherji. Dr. Chiang, thank you very much, and I hope you'll have more talks from pathology as well as molecular biology from you. This is very, very important. I just want to mention my last comment before thanking everyone is that in the listserv I have been going on about this software, that software, Tinderbox, Obsidian, that and this, because nowadays softwares are moving from being passive, that you actually doing, like if you're looking at Word, you are just writing a letter or whatever or manuscript. But nowadays the software are becoming that it actually enhances your intelligence and manages the information. When I say enhances your intelligence, it allows you to make connections between your data and knowledge points. It's not easy to learn these. They are not really difficult, but I can press a chord on a piano, but it's difficult. For me, it's impossible to play a piano piece. And if I show you one thing, then it's easy, but trying to put all these small things together is much harder. And like anything, I can learn it. Then in 2 weeks' time, I wonder, after so much learning, what has happened. But I will say that with the amount of information that's streaming to us left, right, and center, obviously surgical practice is busy as it is. But I think it's worth just slowly, not on a day, trying to figure out all of these things, but to be open to these ideas of using software to manage information so that you can be master of you are on top of the information that comes to you rather than be buried by it. But I hope I'll expand on this further in the future listserv posts or in webinars. So this leaves me to thank Dr. Boop for that fantastic, inspiring lecture and very clear and insightful. So thank you very much, Dr. Boop, and Dr. Chiang once again for introducing us to these fundamental techniques that are moving our field and moving the patient care and moving patient outcome. And I thank the faculty, Dr. Elias Risk, Dr. Suresh Mukherji, Dr. Atul Goel, for kindly taking the time out on a Sunday to help us tease the issues with our speakers. Thank you also for all the participants. I just mentioned earlier before the the webinar started, we do it for the participants, and thank you very much for coming. And it's important to have the participants being active, and also we have a good attendance so that I can bring people like Dr. Boop, Dr. Chang, Dr. Mukherji, Dr. Elias Risk on a Sunday to come and teach you all. So thank you very much to all of you. Dr. Boop, I'll leave the last word to you, Dr. Boop. Thank you.
Yes. Well, I think it's important for all of us to acknowledge the work that you've done, Naren, to bring these educational lectures on various important topics to people around the world. When I look at the names here on the list of attendees, they're from every continent. And for you to put your time in as a volunteer to do this for our profession, I can't thank you enough.
Thank you very much. Thank you very much, Dr. Thank you. And next week we have got Dr. Al Cohen talking to us about medulloblastoma, and that will be the last lecture before the summer recess. So once again, that will be great. And Dr. Boop, I look forward to you being there, and hopefully look to see most of you there. Thank you very much. Have a great rest of Sunday.
Thank you.
Thank you very much. Bye for now.
Thank you. Bye-bye.
Thank you. Bye. Yes.